Hello everyone. We are going to see today's one of the important symptomatology, that is just discomfort or chest pain presenting to OPD or emergency department, that is ED. It is one of the most common presentation to the OPD presentation. So immediately for any patient of chest pain, we should trace them and categorize them based on symptomatology and clinical correlation as myocardial ischemic type of category, and other than cardiopulmonary pain, non-cardiopulmonary pain. If you see the epidemiological data, the non-traumatic acute chest pain, the distribution of its causes or as shown in this diagram, like gastrointestinal causes. Gastrointestinal causes are more than 42%, which includes like gastroesophageal reflux diseases as well as esophageal spasm and any peptic ulcer diseases. Apart from that, the second most prevalent cause is ischemic heart disease, that is up to 32%, 31%. Other than that, chest wall syndromes 28%, pericarditis, pleuritis, pulmonary embolism, lung cancer, aortic aneurysm, aortic stenosis, and herpes zoster. These are the distribution of causes. And we will next see how to approach this chest discomfort. The first of all, you should have in mind the most life-threatening causes should be addressed first. The one of the important cause should be excluded is acute myocardial infarction. Here, the likelihood of acute myocardial infarction increases with these typical features, like any pain radiating to right arm or shoulder, any pain radiating to both arms or shoulder associated with exertion, radiating to left arm, associated with the diaphoresis, nausea and vomiting, and worse than previous angina or similar to previous MI, and described as pressure will definitely increases the likelihood of acute myocardial infarction. In other case, the decreased likelihood of acute myocardial infarction and it is MI is less likely if it is inflammatory location, that is inframammary location, reproducible with palpation, described as sharp, positional, and pleuritic type. Is this type of pain is less likely of acute myocardial infarction. So, if you approach acute myocardial infarction, the risk score or high risk categories can be categorized with these scores, like heart score, which includes like history of highly suspicious, moderately suspicious, and slightly suspicious. The highly suspicious history includes the acute onset pressure type of pain radiating to the arm and associated with diaphoresis. This is highly suspicious history, and if it has ECG showing ST segment depression or ST segment elevation, the such changes include as higher score like 2, and non-specific abnormality include 1, and normal ECG is 0 score. And if you categorize according to scoring by age, more than 65 is 2 score, 45 to less than 65 is 1, less than 45 is 0. Risk factors, more than 3 risk factors includes 2, 1 to 2 risk factors is 1, and no risk factor is 0. The risk factors include like diabetic mellitus, hypertension, obesity, and smoking history. Troponin, the serial troponin, more than 3 times the 99th percentile include 2 score, 1 to 3 times is 1 score, less than 99 percentile is 0 score. The any score between more than 4 is considered as not a low risk, that is high risk patient. You should subject to further evaluation and do necessary management. And the score less than 0 to 3 should be observed and can be sent home after precise evaluation. And other than that, heart score, this is heart score, that is history, ECG, age, risk factor, and troponin, that is heart score. And whereas North American chest pain rule says any yes or no type of scoring system, which includes these 5 type of questionnaires. Any typical chest pain of ischemia is present, any ECG changing acute ischemic changes, age more than 50, known coronary artery disease patient, and troponin more than 99 percentile. Any patient with this, any yes includes, that is not a low risk patient, should be subjected to further evaluation and acute management and should be referred to ED, emergency department. And if you see the clinical profile of all differential diagnosis of chest pain includes this chart. See, Here, first of all, any chest pain should be considered. First thing is cardiopulmonary. In cardiopulmonary, the cardiac causes, first of all, you should consider is myocardial ischemia. We said we can evaluate by history and examination component. The myocardial ischemic patient will come with the typical acute onset of pain with 2 to 10 minutes precipitated by exertion and cold and stress, and which is a pressure type and tightness and squeezing heaviness, and some patient will say typical burning pain, which is located retrosternal, often radiating to neck and jaw and shoulder arms, sometimes epigastric location it will be there. And the myocardial ischemic patient will have S4 gallop or mitral regurgitation, that is rare, and whereas S3 will be seen if there is severe ischemia and heart failure is there, and the complication of myocardial infarction clinical signs will be there. Unstable angina will have increasing pattern, or at rest unstable angina will be there. The typical duration of myocardial infarction is pain usually is more than 30 minutes, and in case other DD of other than myocardial infarction is pericarditis. The pericarditis pain is variable onset and hours to days of onset and maybe episodic also, but the quality of the pericarditis pain will be pleuritic type. Pleuritic type. Whereas the location of pericarditis will be retrosternal and toward the cardiac apex, may radiate to shoulder, and it is usually relieved by sitting up and leaning forward, and pericardial friction rub will be heard on auscultation. The next important differential diagnosis includes vascular causes, that is aortic, acute aortic syndromes, that is aortic dissection. It is a life-threatening cause which should be identified immediately. The sudden onset, unrelenting pain, that is sudden onset, and the tearing and ripping knife-like quality, and located anterior chest wall, often radiating to back between shoulder blades. It is associated with hypertension and underlying connective tissue disorders, and that you will hear the murmur of aortic insufficiency and loss of peripheral pulses is a typical of acute aortic syndrome, which should be identified. The next vascular cause of acute chest pain is pulmonary embolism. This is the important life-threatening cause that should be addressed with these typical features like sudden onset pain, the pleuritic type of pain, and heaviness with massive pulmonary embolism, often lateral side of the chest on side of the embolism, and where the particularly peripheral lung infarcts, pulmonary infarcts are there. That is the location of this pulmonary embolism pain, and associated with the dyspnea, tachypnea, tachycardia, hypotension. These are the typical of massive pulmonary embolism profile, that is clinical profile. Apart from that, pulmonary hypertension, which is the variable onset of chest pain, that is quality is pressure type and substernal location, associated with dyspnea. Dyspnea is important. The signs of increased venous pressure, that is venous congestion, raised JVP are seen. Next important cause in cardiopulmonary group is, that is pneumonia, and pleuritis, and spontaneous pneumothorax. The life-threatening cause among these is spontaneous pneumothorax. This is sudden onset pain and pleuritic nature, lateral side of the pneumothorax, the location of the pain will be, and dyspnea and decreased breath sounds on the side of pneumothorax on auscultation. It is important. Whereas other than that, important date is in non-cardiopulmonary, or this is gastrointestinal. The most common non-life-threatening cause is gastrointestinal causes, that is esophageal reflux, which is a burning substernal or epigastric location worsened by postprandial recumbency and relieved by antacids. This is relieved by antacids is important, but the one thing you should remember, this closely mimic the esophageal spasm, you should remember, which can closely mimic the angina, that characteristically acute onset of 2 minute to 30 minute duration, pressure and tightness type, and retrosternal location, which closely mimic the angina, that should be remembered. Other than that, causes includes peptic ulcer disease, that is prolonged duration of pain 60 to 90 minutes after meal, burning type, epigastric, substernal, relieved with food or antacids, is typical of acid peptic disorder. Gallbladder disease includes prolonged and aching colicky type of pain, which follow usually meal and located right hypochondriac region or epigastric region. Other than that are neuromuscular pains like costochondritis, cervical disc disease, trauma or strain, arpeggio. These are variable duration and onset of type pain, and Usually, costochondritis includes a swollen and tender or joints will be present, reduced by localized pressure, and cervical disc usually exacerbated by movement of neck, and trauma or strain usually they have a history of trauma and localized area of strain will be there. They are reproduced by movement or palpation. Whereas herpes zoster dermal distribution is characteristic, vesicular rash will be there and discomfort will be there. The last one, that is psychological causes of chest discomfort, include emotional and psychiatric condition will be associated with that, and manifest as chest tightness, dyspnea with feeling of panic and doom, variable location, it may be retrosternal, situational factors may be precipitate the symptoms, and panic attacks will be there, depression will be there. This is the clinical profile of the differential diagnosis of chest discomfort. And for approaching this type of pain, we should follow this algorithm. For any life-threatening pain, we should evaluate like this. Any chest discomfort due to an acute potentially life-threatening condition that warrants urgent evaluation includes the urgent warrants evaluation immediate includes unstable ischemic heart disease, aortic dissection, pneumothorax, pulmonary embolism. These are the important life-threatening causes should be addressed immediately. If it is not such category as explained previously in clinical profile, if it is chronic condition likely to leading to serious complications, you should think first then, that is stable angina, aortic stenosis, pulmonary hypertension. If it is not fitting clinical profile into this category, then could the discomfort due to an acute condition that warrants specific treatment such as pericarditis, pneumonia, and herpes zoster you should think of. If it is not fitting clinical profile into these categories, then if discomfort due to another treatable chronic causes like reflux disease, esophageal spasm, peptic ulcer disease, gallbladder disease, other gastrointestinal condition, cervical disc disease, arthritis of shoulder or spine, costochondritis, other musculoskeletal disorder, anxiety states. This is how to approach algorithmically acute chest pain or non-traumatic chest pain at emergency department or in OPD. If you come to recurrent chest pain, symptoms and signs can definitely leads to an definite etiology like localized and sharp stabbing, persistent, reproducible by pressure over the painful area that clinch the diagnosis of costochondral or chest wall pain. Whereas if the sharp pain, radicular distribution exacerbated by movement of neck and back, that definitely cervical disc problem or thoracic spine problem or nerve root compression. Associated with the dysphagia and gastric regurgitation, and may be worsened by aspirin, alcohol, ingestion of certain foods, spicy foods, and relieved by antacids, points towards esophageal or gastric pain, that is GERD or esophageal disorders, acid peptic disorders. Like other than that, intolerant of fatty foods and right upper quadrant pain, tenderness also present, points towards biliary pain, and precipitated by exertion, emotional arousal. ECG during pain showing ST segment shifts, pain relieved quickly by nitroglycerins will be type of myocardial ischemia. This is a approach to recurrent chest pain. Whereas coming to the important last slide here, the clinical profile of important life-threatening causes in already discussed, that is acute coronary syndromes, acute dissection, acute pericarditis, pulmonary embolism, acute pneumothorax, rupture of esophagus. The characteristic of acute myocardial includes constrictive squeezing type of pain radiating to the neck and less severe similar pain on exertion. Coronary risk factors will be there, and you will see the diaphoresis, pallor, S3 gallop, S4 heart sounds, and will be confirmed by serial ECGs, cardiac markers. Whereas aortic dissection is tearing and ripping type of pain, and from the anterior chest to the mid back, the hypertension and Marfan type of syndromes will be in the background history, and key physical findings include asymmetric peripheral pulses, possible diastolic murmur of aortic insufficiency, and chest x-ray showing widened mediastinum, and CT or transesophageal echo will confirm the intimal valve can be visualized. Other than that, important cause is acute pericarditis, crushing sharp pleuritic pain relieved with forward bending, and background history will be like upper respiratory infection followed by chest pain, and other conditions which predispose to pericarditis will be in background history, and clinical findings will be pericardial friction rub, and it can be confirmed with ECG diffuse ST elevation with PR segment depression. Echo showing pericardial effusion is often visualized. The another life-threatening cause is pulmonary embolism. The clinical history profile already we have discussed, like pleuritic sharp pain accompanied by cough, hemoptysis, and the background history patient will give recent surgery. Other immobilization will be there. On clinical examination, tachypnea, pleural friction rub will be there, which can be confirmed with normal D-dimer will excludes the diagnosis. High D-dimer and confirmed with CT angiography or VQ scan will be definitive diagnosis. Pulmonary angiogram, arterial luminal filling defects will be seen. That is gold standard test to confirm is CTPA. CTPA will be gold standard diagnostic test for pulmonary embolism. Coming to the next life-threatening cause, acute pneumothorax. It is very sharp pleuritic recent chest trauma, history of chronic obstructive lung disease, the tachypnea, decreased breath sounds on hyperresonance over affected lung fields will point towards acute pneumothorax history, which can be confirmed by chest radiolucency with pleural space, collapse of adjacent lung segment if tension pneumothorax mediastinum is shifted to opposite side. That is acute pneumothorax with very sharp pleuritic pain, sudden onset dyspnea, and history of chronic obstructive disease like COPD. Emphysema patient will get bulla rupture and present with acute pneumothorax. Patient will be tachypneic and decrease breath sounds on auscultation. And if you do percussion, hyperresonance and over affected lung fields can be seen. The last important life-threatening cause is rupture of esophagus. That is, patient present with intense substernal epigastric pain accompanied by vomiting, hematemesis, recent vomiting and retching history will be there, and subcutaneous emphysema will be seen. Audible crepitus adjacent to sternum will be seen, which can be confirmed with chest X-ray. Pneumomediastinum will be there. Esophageal endoscopy is diagnostic. This is the approach to acute chest pain that is non-traumatic. Thank you all.